Thank you. I thank AIOS, Dr. Somashila, and all others involved in giving me this opportunity. So since this is for the general ophthalmologists, these are some of the thoughts that I put together. So whenever we sit in our clinics and we look at a patient who's got microbial keratitis, I think what we need to do is to go through these 10 steps, and each step is sub part of this talk, and I'll discuss each step further. So if we go through a very systematic approach and approach each step, we'll be probably much better in treating our patients in our day-to-day practice. I can't stress the fact that a detailed history of the present ulceration, the predisposing factors, often patients have a lot of treatment before coming to us, so we need to look at what has happened, what has been the response, any previous episodes and systemic conditions. Always think, why did the patient get the ulcer in the first place? Look for risk factors, and many of these, when you introspect these factors, you would possibly know what is the cause, what are the organisms, what drugs may work well against them, and you could even predict the course of the disease as it progresses. And also very important to know about certain non-infective etiologies which you might pick up, which might be instrumental in the ulcer progression. I always stress that very often patients come to clinic with no sugar report done. Even if the patient denies diabetes or has a normal report a few months back, please do check blood sugar in all patients, irrespective of age and history. And of course, we need to look at other factors which might contribute to infectious disease. Documentation is extremely important. Hand-drawn diagrams are an excellent way because they provide an opportunity to learn the various findings that you see in an ulcer, and in a small practice help you monitor and see your ulcers as they progress or as they improve. And you need to follow a systematic way of drawing these diagrams, which are color coded, and also essential that do not put fluorescein before these diagrams are drawn or the pictures are taken. Digital pictures have a big advantage, especially when multiple people are involved in treating patients, and you can have an archive, and it is much better to document and compare images. However, even a drawing has their own advantages. For example, you could document certain things which may not be always easy to capture, especially with patients having a lot of photophobia. When it comes to diagnosis, typically the approach that we have is to use our clinical thought process and resort to microbiology. However, there are other options which are again having limited access, such as a PCR, a confocal, or sometimes a histopathology. When you look at practice patterns in practice, there are some doctors who would only do a workup and then treat them empirically with virtually no microbiology. Some of us might be able to do a smear test because it's very simple, doesn't need a big lab backup. And some of us might be able to do the whole gamut of smears and cultures. With all these restrictions that we know, we must understand that if we don't have access to microbiology, probably we should treat patients, some of these like this, which have severe infections, which have infections which are often drug resistance, and unusual infections or ulcers which progress rapidly and can cause blindness, to centers where these facilities are available. And there is no role of trying to do trial and error in some of these infections. Our clinical judgment is extremely important because this is the way that we are going to start a treatment even before the smear report is available. And the judgment is important because giving cocktail treatment to patients is less effective, reduces the compliance, and is more toxic, as we all know. And there are situations where the microbiology may be negative and we do not have any data, so we have to still stick to our clinical thought process. And also remember that in some situations, we have unreliable lab reports, and sometimes this can mislead us more unless we put our thoughts back and look at what is happening clinically. So as an average practitioner, I think if we can figure out what's bacteria or fungus, maybe 90% of our ulcers we would be able to manage. However, even in the best hands, to distinguish these two entities is quite a task and a difficult process. So there are several clinical clues which we have been taught right from our residency. However, we need to understand that these typical descriptions are often lost when the patient has taken cocktail therapy for a few weeks and now lands up in your clinic. And that is why we need microbiology in these patients. So based on our thought process and clinical examination, we could start treatment depending on what we think it is, whether it's bacterial, fungal, and the problem comes when we have no clinical clues. It's very difficult to decide, but it's better to err on the side of maybe starting an antibiotic and waiting for the smear or the culture report unless we have strong suspicion of the pathology being a specific, let's say, fungal or a different etiology. We need to do microbiology because it helps to confirm the nature of infection, guide our treatment, and medico-legally it safeguards us from problems which may encounter in patients who progress despite all good efforts that we make. I think there is a change in the way microbiology is done today. So we need to scrape at the active edge, plate multiple media and send it to somebody who is interested in looking at ocular microbiology, and typically at least do a grams KOH and basic media, and then when we have more unusual infections, look at different special stains and special culture media. And when we suspect unusual infections, we have to extend our microbiology workup to have these in our armamentarium. And of course, when reports are negative, or there is a deep-seated infections, we need to do a biopsy to subject it to micro and a histopathology. With limited access, however, confocal microscopy in referral centers could still be a very good way of looking at and diagnosing cases where microbiology may be not able to pick these infections. And similarly, a PCR or molecular biology is something that is really evolving and very useful today in some of the situations. So we started something based on our clinical judgment, and within a few hours, normally we have a smear report which comes back from the lab. We know the smears are quick, extremely reliable, and based on that, we know what sort of organism we are looking at, and we can decide whether we need to give an antibiotic, antifungal, or whether even we can pick up unusual organisms from the smear. So they can be extremely useful, and based on the smear report, we could select what drops we need to use for the given patient. However, the problem will come that smears are often negative. So you have a patient, you started some drops, you got the report is negative, then what? So till you get the culture report, you have to see if the patient is getting better, maybe continue the same thing. If the patient is not improving, you have the option of either waiting till the culture is available. If even that is negative, then consider repeat microbiology or refer to a higher center. The sixth step is, of course, to look at what is the response to treatment. So we know the signs and symptoms to look at when a patient of ulcer comes, and this is where our daily drawings or pictures helps us to compare what's happening. Once we have the culture report, we need to see what to do. It's important to understand that clinical response to treatment is most important. If the patient is improving, do not change anything, just continue with it. However, if the patient is not improving, the report can definitely help us to select alternative medications which may be more effective. And sometimes it might help us to stop some medications which probably are not effective, but just adding to the toxicity. And of course, when we have the sensitivity, we can use drugs or select drugs which are more effective. However, again, base your selection based on what has happened in the 48 to 72 hours till you got these reports. And even with fungus now, we have some options where we could prefer one drug over the other. So you're treating a patient based on clinical judgment, smear reports, culture reports, you're doing everything correctly, but this patient is still getting worse. So now you need to think, what could be the cause? Maybe there's a wrong line of treatment. It's not unusual to get a wrong report of fungus or a bacteria, and then you just close your eyes and treat the report based on what the report says. It could be an unusual infection, it could be drug resistance, there may be a high infection load, poor drug penetration, it could be because of poor compliance, toxicity, As I said, there could be non-infectious factors such as ocular surface disease or an immune-mediated process which we are not addressing, and there may be systemic disease which may be contributing to this. So just go through some of these factors. So for example, you need to figure out whether you're treating an infection which is not resolving, or you're treating now a component which is non-infectious in nature. So we all know that infection is knocked off, but there are non-infectious factors which is contributing to the ulcer not healing. Similarly, there could be immune-mediated factors which we may not have addressed, and there are many patients where there may be a multifactorial combination of these factors which is causing the ulcer not to heal. So if you have drug resistance, of course the sensitivity might tell us which drugs to select, and if we don't have drugs for that particular organism, we need to do a surgery at an early stage. And we often encounter resistance when we have hospital or post-surgical infections, patients with surface disease, repeated antibiotic use, and immunosuppressed in elderly population. Sometimes the in vitro sensitivity is good, but in vivo we find there is no response. So something like a pseudo-resistance might happen with organisms, say like nocardia, atypical mycobacteria, because of high load of infection, poor drug penetration, and these are slowly replicating organisms. And you can also have that if you have not addressed a nidus of infection like the sac, the infection may not come under control. Ophthalmologists often find it difficult to differentiate infiltration, inflammation, edema, haze, scarring, and the transition from infection to resolution is sometimes not well picked up or understood, and we continue to use hourly, half-hourly drops even when the infection has been knocked out, and then we end up in a situation of a non-healing surface. This is where, again, we need to be watchful whether what exactly is happening and why the ulcer is not healing. This patient was a post-MMG SJS patient, came to me with a total epithelial defect with an annular ring infiltrate with stromal melting, and he was putting 16 times moxifloxacin and 2 fortified drops, all 16 times a day. So basically in this situation, we have to stop everything, give them lubricants, oral doxycycline, and the surface luckily healed, and I didn't need to do any intervention in this patient. So these can be tricky situations. What looks typically infective, microbiology was negative, and a high index of suspicion and clinical judgment and close observation is what is required. Toxicities typically might present like a PED or a stromal melt. You can have sterile hypopion, and all these factors are much more accentuated when you have an unhealthy ocular surface. So unhealthy ocular surface will easily pick up and develop toxic signs due to medication. Sometimes in patients with ulcers, we need to check corneal sensation, look for the tear film, lid lash problems. There may be a foreign body which has not been addressed. Sometimes we have to flip the lid to figure out that this is actually an allergy and not an infectious ulcer. So we can have several of these factors which, if not addressed or picked up, it just looks like an ulcer to an average clinician, and he keeps treating with antibiotic, but they do not seem to be getting better. So we need to figure out the non-infectious surface and immune pathologies. The step 9 is surgical management. So if you have a patient we know with a large melt or perforation, we of course do a therapeutic graft. Small perforations we might manage with a glue bandage lens, and in early, if we pick them up early with thinning, we could consider using collagenase inhibitors and tarsorrhaphy. Therapeutic PK is something that we often need to do when we get patients who are coming late with involvement of limbus, extension to sclera, or very deep anterior chamber involvement. And in these situations, it's always better to do it early rather than late and wait for end stage disease where it becomes very difficult to salvage. You could do a DALK or a PKP, and it's always wise, and you need to decide what's good in your hands and how deep the infection is. Some of the adjunctive management is not to use NSAIDs in corneal ulcers. They can cause epithelial breakdown and precipitate melts and perforations. You can always use collagenase inhibitors. Atropine is again something that we all need to remember to use. And anti-glaucoma medications, we avoid PG analogs normally. Steroids, though there are certain indications in at least in a private practice situation, in a non-institutional setup with limited resources, it's best avoided in all infectious ulcers, specifically never use in fungal, nocardia and mycobacterial ulcers. In bacterial ulcers, once the infection is under control, you could consider them, but again, one needs to be extremely careful. Similarly, in acanthamoeba, in very selected cases, with experience, one might need to use steroids. Cross-linking is something that is evolving for certain drug-resistant infections and refractory cases. This is the last slide of my talk, but I'll just have 2 more slides or 3 more slides to show you, since we have fungus and bacteria are the predominant infectious etiologies, how do we manage? So this is based on the TST protocol, where typically when a fungal ulcer walks in, we start with topical natamycin. However, if the ulcer is extremely large or deep, we might consider using an oral azole with it. Similarly, patients who are post-graft or who have posterior segment involvement, limbal involvement, we might consider using an oral azole. If the response is poor, we typically add a second drug, which may be voriconazole. If the response continues to be poor, we have the option of using intrastromal or intracameral antifungals. And if still patient doesn't respond, consider doing a therapeutic keratoplasty. Similarly, in any of these ulcer patients, if the corneal surface is sloughing, there is thinning, perforation, probably instead of giving intracameral or intrastromal, which may not hold the tectonic strength of the cornea, it's better to straight away do a graft. Also today, when you look at an ulcer which is not healing, which looks fungal or has been reported as having some filaments, rule out pythium infection, because this is something that might be not the basic reason why the patient isn't improving. So this is one algorithm for bacterial keratitis which I try to follow in my clinic, where we have small ulcers, peripheral, not really fulminant, you can use monotherapy. However, if they are large ulcers or fulminant ulcers, then you have to do smears, as I said, or some sort of microbiology. If the smears are also negative, use fortified standard combination therapy. If the smears are positive, look at what your clinical judgment and smears, whether they match or not. If they do not correlate, use standard therapy. If they do correlate, you can look at what is the risk of drug resistance in that given patient. If the drug resistant risk is low, you can use your regular antibiotics. However, if it's high, you should try to add a higher generation antibiotic in the treatment regimen. And as I said, when you have culture reports, if the patient is clinically improving, don't change anything or use or eliminate the ineffective drugs or replace with more effective drugs. However, if the patient is worsening, you can change as per the reports. Just to give you an example, for example, you have a large contact lens ulcer with pseudomonas, clinically feels like pseudomonas, smears are GNB. The resistance risk that you feel may be low, maybe because it's community acquired. You could use 2 antibiotics which work well against gram-negative organisms. On the contrary, if you have this patient coming from the ICU or from a hospital environment where there is a very high chance of having drug resistance in these gram-negative bacilli, you could consider using a higher generation of antibiotic from day one, because you have very little time to sort of lose. Similarly, you could have, so based on basically the risk of resistance in situations where there's a very high risk of having resistant organisms, you could consider using a higher generation of antibiotic right at the go. However, these type of protocols are something which are not validated. So it's just a thought process that I've put forward. Each of us has to decide in our own practice what works best with the resources that we have, so that we are able to manage our patients better. And whenever in doubt, it's always wise to send the patient across either for a second opinion or to a higher center where they can manage these cases better than what we can all do. Thank you, and I would hand over the mic now.
That was a wonderful presentation, sir.